Hello, everybody. This is Dr. Scott Worden, the TOS guy, live streaming from beautiful downtown Sunnyvale, California, where we're starting to get a little taste of fall, and it's really beautiful out. But our passion, besides the changes in the weather, is TOS. And tonight, we'd first of all like to apologize for the technical challenges we just had. They're all my fault, actually. I think the internet is working fine. Anyway, we're up and running, and we're here to introduce a guest who's a personal friend and a great guest of ours from past visits as well, Steve Talajkowski, physical therapist par excellence, who's got decades of experience with TOS. Steve, it's great to see you.
Hey, thanks, Scott. Thanks for having me. I really appreciate the chance to talk about TOS, and I want to thank the people that have been watching. And I have received some comments in the past about some past presentations, and they've been positive, and I think they've helped. So that's the reason I'm doing it.
Awesome. All right, today we're going to have a pretty big, broad topic that I personally am looking forward to a lot.
Oh, cool. Okay. Well, the topic today is going to just be like what I've learned over my 26 years of treating thoracic outlet syndrome and my 31 years as a PT. So I met Peter Edgelow, and I want to give a shout out to Peter. Let me see if I can get this to. Oh, sorry, that was me. Okay. Yeah, here we go.
There's Peter.
Okay. I met Peter 26 years ago at the same clinic I'm working at right now, the Hayward Clinic, and Peter was well known in the Bay Area already, and known for treating thoracic outlet. I didn't know that was why I was going there. I just knew that he was a good clinic and he was a good clinician. Peter passed away in 2018. And so I worked with Peter for about 14 years. During that time, I got the chance to treat more and more thoracic outlet patients as Peter's schedule kind of got smaller and smaller. And then when he did sort of retire, again, before 2012, I think. Don't hold me to that. Then I started to take over the TOS program at the clinic and continued to kind of grow and become part of like this group with Scott. And here I am. So I do have some things to share. So we can get right to the next first slide. Okay, first, seems obvious. TOS is a syndrome, but people are individuals, their problems are unique, and TOS, I think, is a bad syndrome, and I'm going to explain that in a minute. So what's a syndrome? Well, a syndrome is it's a group of symptoms which consistently occur together, suggesting a certain disease. So an example would be carpal tunnel syndrome, or cubital tunnel, or rotator cuff syndrome, patellofemoral syndrome. Those are orthopedic ones. But they all have sort of a pattern around them, which makes them easy to diagnose. Now, TOS has a pattern of symptoms, and some are numbness and tingling in the hand extremity. It could be pain and ache and burning in the neck, shoulder, and hand. Upper extremity weakness, the loss of range of motion, swelling, coldness, color changes. But if you look at that, that's a big list of symptoms, and it's a pretty wide range of areas that it's in. I've shown this picture before. This is a picture showing the thoracic outlet, but actually it shows all the tunnels that the nerves travel going from the spine to the extremity. So that cone area, if you can see it, it's like 3, 4, and number 5 is not very well shown, but that's the thoracic outlet. The problem is we have 3 spaces: the scalene triangle in the first rib, the clavicle and the subclavian muscle and the first rib, and then the pec minor. So 3 spaces. We have 3 tissues: the brachial plexus and the subclavian artery and vein. So we have either neurogenic or vascular problems. And within that whole section, there are all sorts of anatomical differences, anything from cervical ribs to anomalies with the scalenes, anterior and middle, first rib problems, anomalies with the subclavian, the clavicle, the pec minor. So you can see that it's not one area or one thing that causes thoracic outlet. And that's why I kind of called it a bad syndrome, because it's really hard to pin it down. Like, for example, say something like a carpal tunnel. So my next slide, and besides that, there's other issues. There's issues in the spine, the shoulder, peripheral nerve entrapments. We mentioned that again, carpal tunnel, cubital tunnel, radial tunnel, tendonitis, medial lateral epicondylitis. We have myofascial pain, fibromyalgia, chronic pain, complex regional pain syndrome, Ehlers-Danlos syndrome, Raynaud's. These are all issues that can exist at the same time as thoracic outlet can exist, and which confuses it. And I'd also say probably there are some problems in there that are diagnosed as something, let's say carpal tunnel or cubital tunnel, that aren't really cubital tunnel or carpal tunnel. They're probably thoracic outlet. And I can't tell you how many patients I've had who've had an ulnar nerve transposition, a carpal tunnel release, and their symptoms didn't get worse. There's also a problem of history. It's how old is a person who has thoracic outlet syndrome? Are they 50 or are they 13? It makes a difference in how we treat them. When and why did it start? Was it work related, sports, exercise and recreation? I'm kind of breaking that up. I mean, sports could be something where you're actually competing in a sport, or exercise, recreation could be just going to the gym or skiing or cycling. It can also be trauma, like a motor vehicle accident. But sometimes people don't know what happened. So it's none of the above. They're not sure how it started, how their TOS symptoms started. They just started. My second comment then is it's difficult to find people who can treat thoracic outlet syndrome. And even I have a hard time. This group has been great in that we've brought together experts and resources for people to get help. But even in the Bay Area, we've had some significant losses of experts in the field. And there are people that are taking over, but they're few and far between, and it's sometimes hard to get in. I think TOS kind of falls into a void or a blind spot. It just isn't something that one person seems to have a good handle on. So patients often see a spine doctor, maybe an ortho or a shoulder doctor or a hand specialist, and sometimes their findings are either relevant, but I should say they're there, but they're not relevant to the kind of symptoms they're having, or they don't find anything. A lot of times, urologists are in the mix, and one of our good uh, Tracy Newkirk was a neurologist here in the Bay Area who was an expert in treating TOS. But again, there aren't that many of them, and they do more things than just treat TOS. Surgeons are good resources, but if you're not a surgical candidate, surgeons are probably going to take a case or manage a case of non-surgical TOS. And often we go to like the physiatrists or pain management doctors. Sometimes people go there because everybody else doesn't know what to do with them. Sometimes they're the first people that might even suggest it's thoracic outlet syndrome. And here in Hayward, um, I get quite a few patients from a pain management group or groups, and they're the first person that brought up TOS. The other people are acupuncture chiropractors. I don't know a lot of acupuncturists and chiropractors. Like any profession, there's good ones, I'm sure. I just don't know what they do. Massage therapy is pretty kind of a wide range of techniques. I don't really necessarily suggest people go to massage therapy, but I'm not against it. And even physical therapy. Unfortunately, there's a lot of physical therapists that don't have experience with thoracic outlet, and they either don't know what to do or might be too aggressive in their approach. And so I end up a lot of times seeing those patients. So my next slide is then what? you can't find the person who's going to help you, often you're on your own. You're searching for the next specialist. You're traveling to see specialists if you have the resources. You seek alternative treatments, but not sure what they are or if they're safe. You spend money on all sorts of devices and equipment, a lot of devices, a lot of pillows, a lot of stretching devices. People scour the internet for information, articles, forums, not sure what to believe. And, things can sound pretty bleak. And I think that people think, does anybody really know anything about this or even care? And most people are just kind of holding it together. They're holding a life, a job, relationships, and they're trying to explain to their friends, their family, their employer what's going on without sounding like they're crazy. And it's got to be frustrating when you have TOS and then a year later you still have TOS and people are wondering why you still have it. And the problem is, not everybody, but most people look pretty normal, but they don't feel normal. So my next slide. So that's why I'm here. I use the INVEST program. That's Peter Edgelow's program, the Edgelow Neurovascular Entrapment Self-Treatment Program. And it works. The problem is it's just not for everybody. But the majority of people see improvement. The problem is some people probably do need surgery. And even though the INVEST program didn't help them avoid surgery, I think it helped them guide them in the right direction. One of the problems is the INVEST program takes time. It can be over a year to see improvement, and sometimes more, sometimes less. People don't always have the time to do it, and they have a lot of life commitments. And I think another part is the program challenges people's belief systems and what they think they need to have done. So a lot of folks have ideas of what they need to do, and I'll come up with the program, the INVEST program, and it doesn't quite fit. And sometimes it seems like it's not a right fit. But next slide will show stretching and strengthening exercises are not the way to start treatment for TOS, at least with my patients. Now, I say that because when I see a patient and I ask what they've done before, well, first of all, they're coming to see me, so they're still having trouble. And I ask them what they're doing before, and a lot of people say, well, I went to, I'll say, physical therapy. We did some stretching, some nerve glides, some scapular strengthening exercises, and it made my symptoms worse. So the idea of stretching and strengthening is not the way to start is not my rule. It's just what happens to patients. Now, I'm sure there are patients that might be able to stretch and strengthen, and I'm not saying it wouldn't help. I just don't see those people. The people I see are the ones where it failed. And I would say that almost 100%, and I probably would say 100% of people, when they come in, they say it hasn't worked. And the problem is they don't know what else to do. Now, eventually, stretching and strengthening are added and they're necessary. This will be part of what helps to keep you better. But we cannot add stretching and strengthening exercises until the nervous system's calmed down. The exercises cannot aggravate the TOS. If they do, we don't do them. So when people ask me, well, when can I do stretching and strengthening? I'll say, we'll try it. And if it aggravates your symptoms, you're just not ready. Next slide. Okay. Another thing I've learned is there needs to be a fundamental change in approaching life and movement. But the good thing is You don't have to be perfect to get better. So part of the program, and a big part of the program, is awareness and listening to your body. And while the goal is to return to normal activity, to work and to play, it does not mean that a person can do or should do whatever they want. But the goal is to do more and more of what you can. But today, the rule is you do what you can do that doesn't flare up your symptoms. It means to take time to take care of yourself. And you will gain control by understanding the problem. The last thing is I like to say is this isn't your fault. You did not deserve to get thoracic outlet syndrome, but you do bear the responsibility of getting better. So when I talk to patients and I ask, what happened? A lot of time it's kind of a similar story. It's like, I was working hard, long hours. My posture's bad. My ergonomics are bad. My job is stressful and demanding work. I've got a busy personal life. Okay. Sometimes it's an accident or trauma. Sometimes it's just competing in a sport, exercising maybe too hard. But I tell people this is what everybody does. This is the problem with society today, all the things that are listed there. That's not the reason you got TOS. Those things aggravated it, but I'm convinced it's anatomy. I think the anatomy, I mentioned, I showed that picture early on with the scalenes in the first rib and the clavicle and the subclavius and the pec minor. Something's going on there. And I think there's just a predisposition for developing TOS. And so you're doing the exact same things that everybody else is doing. It's just that you don't have the same ability to do those things. And the problem is you don't find out until it's too late. So I also think people got wrong advice. I think they've got the wrong treatment. They've got delayed treatment. They have insurance companies and work comp and even medical experts that either deny treatment, deny they have it, say they're not going to cover a treatment or a procedure. And so all those things are out of your hands. So again, I want to say it's not your fault, but there are answers. Scott has answers. The group that we are with have answers. I think I have some answers. So whatever happened, it happened. And now we got to take care of it.
Thank you, Steve. I would like to ask you a couple of questions, if I could, to foster discussion. But I'm going to actually inject my questions first. Jorge and other people, if you can hold for a little bit with your questions, we will definitely get to them. I was taking some notes as Steve was talking. Steve, you talked about the lack of objective criteria for neurogenic TOS. How do you work yourself and with other members of our community to narrow that down, to convince yourself that you're not working on carpal tunnel syndrome, let's say?
Um, well, a lot of times, I would say probably because I tend to see people that are probably further along into the process. So I would say a lot of people come in and say, "Hey, I had an EMG, it was negative, or mild carpal tunnel." For example, I had a MRI of my neck. I got a small bulging disc, but not things that would explain what kind of symptoms I have. So I'll sometimes already have that information. Now, I also think when if you describe carpal tunnel, it's pretty specific. So when people have a pain pattern in their in their thumb, index, and middle finger, and it's from the wrist down, and it happens in certain situations. I think even if I didn't have an EMG to say that, um, if a person's not describing that, then I'd probably say it's probably not one of their problems. But when we look at the EdgeLo program or the Invest program, so I do a series of um, measurements during my exam um, to measure kind of neural mobility, sensitivity to movement. So there's cervical movement, there's arm movement, there's upper limb tension mobility tests. So
Mhm.
there's all different sort of mobility movements that sort of uh, I'm looking for the onset of sort of nerve related pain. Um, I also do strength tests and I also do hand temperature tests.
Mhm.
Um, but I would also say that when I do, like, say, a hand temperature test or a strength test, I'm actually looking for, um, as a patient doesn't exercise, it's kind of fascinating, but I'll see people's objective measurements change
Mm.
right after the exercise. So, an example would be hand temperature. So, you measure someone's hand temperature, and we do the index and pinky finger. And let's say it's cold. Let's say one hand's colder than the other. I don't take that as that's my baseline. They do an exercise where the whole goal of the exercise is to relax the scalenes, take tension off the brachial plexus, open up the space in the thoracic outlet. When they're done with the exercise, I'll check their hand again,
Hmm.
and it could be warmer. They could have greater range of motion before they feel symptoms. They could turn their neck and they could go further before they feel that tension. And so I'm using after years and years of years, like those for me are signs of nerve irritation.
Mm.
And then I'm looking for an exercise that addresses a specific problem and then to see if that problem changes. So, and this happens with a lot of physical therapy treatments all over the body. If I treat subacromial subacromial impingement, and I do something that I think is going to fix subacromial impingement, and after the treatment they have more range, I'm thinking, well, I must have done it. If they had a cervical issue and I treated subacromial decompression impingement and it didn't get better, it's because they don't have subacromial impingement, they
Right.
have a cervical issue. So it's kind of playing back and forth with, I think it's this, I'm going to do that. And then
Mhm.
if I do this, I want to see what the result is. And if the result is positive, then I believe I'm on the right track. Now,
Uh,
you're asking that question constantly throughout
Right.
treatment and throughout time. So it's not a question you ask once, it's a question you're always asking.
Great point.
Yeah.
Of interest, there was a paper written in the 80s that very few people have looked at by a fellow named Cheng, Cheng, and by Selena Ellis's dad, Vladislav Ellis, very
Yeah.
smart guy. And during surgery, they would do thermography of the hands, and they found that the temperature of the hands would change depending on what they did surgically, whether they removed a redundant anterior scaling muscle or they did neurolysis, but they clearly found that some surgical techniques changed the temperature of the hands objectively in the middle of surgery, similar to what you're talking about. And Dick Braun, who's a retired hand surgeon in San Diego, he actually did a work measurement, the area under the curve, using, I think, a BTE machine. And then he would do it before and after scaling blocks, and he found a big difference. So these are tantalizing little clues for which I have very little explanation and that are fascinating to me.
Well, and then there's another I flipped this around because I just said I was looking to do something. I have an attention. The exercise, let's say the first exercise in the invest program, has an intention of what it's supposed to do, and then I see if that if by taking tension off the brachial plexus again, diaphragmatic breathing, relaxing the scalenes,
Mhm.
gentle movement, opening the space, is there a positive outcome? Did the hand temperature go up? Well, what happens with is if you're at a computer doing something and your hand temperature goes down. To me, that's telling me that you're compressing that space. So we can use these objective measurements not only to help direct you into a way that improves things, it can also help alert you that something negative is happening. And I would rather have a a smaller objective measurement like hand temperature be the first sign rather than an hour later, oh now my arms are killing me because I've been on the computer for too long. Um, and so we're using those objective measurements almost like ahead of the curve so that we're seeing an improvement objectively. And even I'll even say the first day, I can see sometimes a significant change in hand temperature and range of motion. Doesn't mean the person feels any better.
Hmm.
I mean, why would their nervous system didn't sort of calm down in 10 minutes? The space opened in 10 minutes.
And there's still healing and recovery to occur. It's going to
Right.
take more time.
So the
Not not
mantra or
not to
the
mention the
mantra is
fact that we know lots of people have different anatomy.
right.
So you already described that some people come to you and do great. A lot of people, but not everybody.
Not everybody. And
And we also know that surgery has outcomes that are good for a lot of people, but not so good or worse for other people.
right,
And so, bearing along this question of how do we make an objective diagnosis, I think we're all really weak in this, and our efforts together are hopefully paying off over time as we look at imaging and different techniques like an upper limb neural tension test and the outcomes from procedures that you do, what surgeons do. So I'm
right.
going to interrupt for a second here from my own questions. Jorge has been patiently asking questions. And Herb, if we can put up Jorge's questions so Steve can take a crack at them. All right. Well, I guess we're going with someone else's story. Okay. Main focus. Thanks for a question. Regarding your first rib mobilization device, Steve, what diameter dowel is used? A half an inch? And what type of glue is used to glue the dowel to the pinky ball?
Oh, it's just it's a half inch. I mean, if you're gonna make one, you just buy one of those uh, uh, pink rubber balls on Amazon. It says pinky ball on it. You drill a half-inch hole in it. Halfway through, you take a half-inch dowel about 18 inches long, and you just put glue in there. I mean, I have I have wood glue, but I wouldn't doubt that. I've never used Elmer's glue, but it's not anything special. It's just regular old yellow glue. um,
There's a factory gearing up right now in China now that they have the secret recipe and they're going to
oh,
start making these. I
right,
tease.
yeah. Um, I mean, I do. Well, I sell them, but they don't make it doesn't make sense to ship them because the cost of the shipping is cost more than the
Hmm.
ball cost. So I tell people, unless you're completely unable to, drill a hole and cut a dowel, which some people can't,
Yeah.
so it's probably easier just to make one. Um,
Okay. I think main focus has some more questions. We have other questions from people. Again, I'll defer my own for a little bit. Herb. Okay. So, how do you use the first rib mobilization device, and how many sets and repetitions? How many times per day do you do it, Steve?
yeah, it's probably not the question I can answer right here. I think, and the reason I'm saying that is that if you look at the protocol, the INVEST protocol, the rib mobilizer is the fourth exercise, which means you've done 3 exercises to get to the fourth exercise. And I'm very if I've learned another thing is that I've just learned to stick with the program that Peter developed. And every time I find myself, and I don't find myself doing it anymore, but back when I did sort of find myself veering off and trying something else, I always felt like I end up going
Mm,
back. Or if I'd ask Peter a question, he'd always sort of say in a nice way, like, "Well, did you do A, B, and C? Like, why'd you go from A to D?" So I progressed the program starting with exercise 1 because exercise 1 and exercise 4 are related, and exercise 4 is the first rib mobilization. So its success depends on whether you can do exercise 1 correctly. Um, and it's dependent on if you do the exercise, because in this case, your intention is to mobilize first rib. So I'm expecting to see an objective improvement. If I don't see an objective improvement, and I would take a step back in that there are times when you can see no change and that's still okay. But if you see a worsening of objective signs, we don't either reassess the exercise or we don't do it. And I mean by reassess is making sure you do it correctly. So, so it's hard to sort of, and I'll tell you, the pinky ball exercise gives people the most, is one of the exercises that gives people the most trouble because it's not inherently, it doesn't make sense to people. When I tell them their first rib is up here, I swear to
mm,
God, half the people go like, I had no clue it was up there. And then you show them a skeleton and they go like, well, yeah, I can see it's right there. So it's, and people tend to be too aggressive with it. They
mm,
tend to sort of like, they put it in the wrong spot. They kind of do it too much and they make it sore. And then they get, you know,
mm.
I don't want to say discouraged. Sometimes we just,
What is your goal? Can we discuss briefly what mobilizing the first rib means?
so, um, so when I'm putting so the way the exercise works, and here I am talking about it now, but you're lying on your back, and then the ball and stick is coming from behind your head, and it's kind of almost coming straight down onto the posterior part, the part of the first rib where it's getting close to attaching to the spine,
Mm,
and then um, as you're doing your pelvic tilt, your body's moving up and down. So as you move one direction, you move towards the ball. As you move the other direction, you move away from the ball. What I think is pretty fascinating about the exercise, even today, is that as you exhale, you move towards the ball. So you're pushing on the rib during the exhale,
mm,
which makes the most sense to me because if you're exhaling, you're relaxing the scalenes, right? The scalenes are inhalation muscles.
uh,
Um, as you exhale, and the way muscles work, if you contract one muscle, the muscle that does the opposite thing needs to relax. That's the only way we can move our body is if I do a bicep curl, my tricep lengthens.
mm.
So what's kind of genius about it is we were doing the mobilization during the exhale when the scalene is relaxing. But here's the point. I mean, for some people, this exercise, it's almost like a game changer.
Hmm,
And other people go like,
hmm.
I don't know,
It's a heterogeneous
goes back
patient
to like, well,
population.
where's the compression? What's happening? Is the first rib need to be mobilized? I mean, so this is where you start to ask the questions, um, but the answers are individual.
I have to carry my soapbox with me. This we know from 200 years of lots of people looking into this, patients are different. There is no one cause of neurogenic TOS.
Right.
And the homogenization of it starting in 1952 with uh, God, what was his name who coined the term? It takes everything that we've learned, and we are still learning now about anatomy on imaging, for example, that there are different patients because there's different anatomy and because there are different causes that the anatomy does different things because we're dynamic. We move. The shoulder is the most mobile joint in the body. So I'm endlessly intrigued by this that we have papers coming out talking about surgical outcomes. And I first look at it and say, how do we know these patients all have the same mechanism? Well, do they all have the same disease? And you're
Yeah,
describing that beautifully. You've been doing this for how long? And you still see patients that are marvelous and do great. And then other patients just, it has no effect, just supports the whole idea.
right. And it's and what I don't what I'm always a little bit afraid of is that, you might try something and it doesn't work, then people think, well, you're supposed to know what you're doing. And I'm going, you know, I mean, it's a bit of I always try to tell patients that it's you're we're kind of working through this together. And I'm trying to get there the fastest I can, but that doesn't mean it's the most direct way either. And there are going to be some sort of wrong turns, some detours, some dead ends. Um, but the foundation of the program is always there. And I would say that one of the foundations is don't irritate the nervous system, open the spaces, and you do that through the simplest things. And this is maybe a problem too, is because you start talking about breathing and posture, and it's almost like it can't be that easy. And I'm
Yeah.
going, it's not easy. Matter of fact, that is a hard thing to control. And our
What you
technology has
do,
created
Steve, is very
this
complex,
problem.
multiple
What's that?
steps. Yeah, I'm reminded of a scene from Seinfeld where George Costanza has to have some kind of biopsy. And a week later, he calls up the doctor's office and asks about the biopsy. And the nurse says, "Oh, it's negative." And he starts freaking out because he doesn't understand what the process is. The word negative means
Right, right.
good.
Yeah.
And he thinks he's going to die. Um, anyway, main focus. I think we have some more questions. And I'd like Steve to be able to help you with all of them. All right. What is included in your Invest program toolkit? Is there a manual or a video? How much does it cost? Can the items be sold separately? So here's a chance to plug what you do because you do a great job. I can say that from many patients we've seen. So sell us on the Invest program. Tell us how good it is
Okay.
and how you can find and learn about it and how much it costs if you want.
Okay. Well, I would, um, I mean, for years, Peter was selling. Well, he was not always sort of personally selling it, but selling it to vendors that were selling it. Um, and there's a handout which is needs to be updated. It's my job. Um, there is, the pinky ball. There's a foam roll. There's a exercise ball, which most people would just naturally have anyway. So, like when I see a patient, and the things they probably don't have would be the pinky ball and the handout. Um, there's an It's the oddest thing, and I don't know if I can even explain it, but we do this kind of air pillow that Peter somehow found or decided to use, that we use for pelvic tilts and thoracic mobilization, that you cannot find anywhere unless you buy a box of 250 of them for $400, which makes no sense, right? Um, that was part of the kit. And then we start getting into the thumb strength testing, which is sometimes part of the program and sometimes not. So the exercise stuff is pretty minimal as far as cost. Um, I do have an issue, and I'm gonna solve it, I hopefully soon. But Peter did have a video, um, and I felt uncomfortable selling the video with, and I've asked his family, and um, they haven't been sure if they want me to do it, but they also haven't said I can't do it. So it's been there's a lot of things going on, I think. So I always felt uncomfortable selling the video and then trying to sort of make money on it. Um, so I've been looking at just making my own video and selling it, but I don't have that. So what I do give people though is if they work with me, I take little video clips of the exercises just to sort of show them like one way it's done because it's kind of hard to look at the handout sometimes and it's just a
Mhm.
drawing and it's sometimes hard to understand movement just through a drawing. If I see people remotely, which I do on Zoom, often I'll have them take videos of themselves doing the exercise and I can critique them either live or they can take a video at home and send it to me
Mhm. Mhm.
and I can critique that. Um, but I do believe the program was developed to be self managed. I just feel like my experience has been it's hard for people to self manage it. But that doesn't mean they can't and they shouldn't try. They don't have to see me or pay me to see it to do
Oh,
it.
with technology we have now, you can do live consultations, video
Right.
consultations, and really provide that fine feedback.
Yeah.
I'm going to ask main focus a question. I know you have some more questions. I'm going to come back to you after we get some other folks on here and get their questions so we keep everything fresh, if that's okay.
Yeah.
All right. And TOS Education, our sponsor, has reminded us that generally the greatest cost is physical therapy appointments with Steve, our expert.
Yeah. I
All
mean,
right.
supplies are minimal, I think. I mean, you can, and people might buy. I mean, I buy a thermometer, uh, to take hand temperature. They're probably $15. Again, foam rolls are cheap, balls are cheap, pinky
But
balls are cheap.
expertise, your
Yeah,
expertise is
expertise is,
worth a lot.
it's never been meant to be a high cost on the equipment end. I mean, Peter may try to make it clear that he didn't want it to be he kind of MacGyvered a bunch of stuff together, and it's kind of it's it's interesting.
Peter was amazing, and we all miss him for a lot of reasons.
Yeah,
One more question from Main Focus: can there be second rib involvement, and if so, what can you do?
the I don't think if there is a second rib involvement, I don't think it would be significant. I mean, there is a what I find is like later on, like when people are feeling better, but they still have like maybe limited shoulder mobility, and we do some. It's not in the handout. We do some second rib mobilization with the pinky ball. Their shoulder range of motion improves, but I think it's not. It's when they're already feeling better, and we can mobilize that area. But there is probably a slip, that T2 nerve root, which might shoot up part to the T1. So I've always felt that there was, in some cases,
Hmm.
T2 could be more involved than in some people than others, but I would probably say less people than more.
So actually, I have seen rarely what's called a post-fixed brachial plexus, which has a T2 contribution,
Yeah.
and a prefixed brachial plexus, which has a C4 contribution. But I can tell you they're pretty rare. And where the T2 nerve root comes out, it's hard for me to imagine. Granted, it's rare, so I haven't seen enough cases. I don't know that anybody has, but it's hard for me to imagine from the anatomy that that nerve would be tangled up in the shoulder motion and the typical either tension or compression mechanisms. It's possible, but I think it's pretty rare, and it wouldn't be my first focus unless there's some evidence otherwise.
Right. So, like I said, I think when we work on T2, it's more later on. And I think it's just more thoracic mobility than probably is nerve.
Okay. Main Focus, thank you for all the questions and the involvement. We really appreciate it. Hi, Jorge. Thank you for the talk, of course. Thank you for attending. Can you mention, this is a great question, which posture muscles do get specific exercises in the program? I'm going to expand that a little bit if you talk in general about how posture is affected by TOS and how treating posture can improve TOS.
Um, so if I'm getting the question right, but so here's what happens with patients, and they, I mean, they'll come in and they've got kind of the rounded shoulder, sort of you know
Can you demonstrate?
protracted scapula,
Can you
and
demonstrate, Steve, what that means? Rounded
yeah,
shoulders.
yeah, and then of course the problem is that goes with this whole other pattern. So it goes with uh, the a slouch at the pelvis, increased thoracic kyphosis, a forward head, a rounded shoulder. So when people are saying, well, I need to stretch my pec, they have this idea, which I'm not saying is wrong, but I need to stretch my pec minor, and I'm going, your pec minor is just going in the same direction your body's going.
Hmm.
So if we're going to open up the space, we need to put you in a position that brings the shoulders back, brings the head more level. The pelvis has to be rolled forward. A rib cage has to come down just a hair. And so we start talking about changes in posture that in reality start at the feet and the pelvis. Even the position of your knees, are they close together or are they further apart? So you can't just stretch the pec minor and expect your posture to get better. And because and even if you could stretch the pec minor without irritating TOS, and it's difficult
Mm.
at the beginning, you would still go right back to the position that created that tightness, that weakness in the scapular muscles. So I would say we're looking at we got to change the posture first, calm things down, and then we start to work on, because you can make corrections day one that are meaningful, and your pec minor is still tight and your scapula is still weak. But we've changed the concept of what posture is, and I didn't invent this. This is a posture stuff that's in several good books on posture. Is it starts from the feet, pelvis first. And so we cannot change the pec. We can't look at things individually anymore. And I'd also say I I believe there's a bit of a protective pattern with this sort of pec minor elevated shoulder that's from irritation of the nervous system. And and so by calming things down, people's posture improves without making and as long as they're also doing those changes I mentioned earlier. But doing a stretch isn't going to change it.
So is it fair of me to say that when your scapular muscles get weak or when your pec minor muscles get too tight, your shoulders move forward relative to the rib cage?
Right. And
And
it
so,
compresses that space. It brings the head forward. The head
mm,
forward contracts the scalenes,
and
right?
now with your head forward and your shoulders forward, your lumbar spine has to change because
Right.
otherwise you tip over.
It it's all part of the same thing. So when we're talking about putting the shoulders in a better position, that's like the last, well, it's not, it's the
Mm,
second to last thing. The first thing is, where are your feet? Where are
mm,
your legs? Where's your pelvis? Where's your rib cage? It's almost like you do all those things and your shoulders just come back
mm,
without even doing anything. And then you do a little correction with your neck, and it's you're I'm not saying it's perfect yet, because people have stiffness in their low back, they have
mm,
thoracic stiffness that we have to they have cervical that we have to address. but I can change someone's posture meaningfully enough at the beginning to make an improvement.
I
And then we
think
can go
that's a
further.
really, really great question that we can keep going in detail. I think that's a really great question. And your approach to it is that the posture is secondary, right? It's really
Well, I mean, we have to change posture. And I would even go further. We talk about diaphragm breathing,
mhm,
and I'll do this day one again with patients. We do the diaphragmatic breathing on the floor and table, whatever, trying to breathe from the diaphragm, relax the scalenes, contract the abdominals, relax the scalenes. Or I should say, when you breathe from the uh, diaphragm, you're trying not to activate the scalenes. When you exhale with a little bit of force, you relax the scalenes. Um, and then so we I talk to people. They say, "Well, that's what you're going to do one exercise." Of course, I have something else for them to do, but but they're going, "Is that it?" And I'm going, "Okay, so I want you to sit down and I want you to breathe from your diaphragm." And they go, "Well, that's hard." And I say, "Well, the reason it's hard is because you're slouched." So not only now am I slouched and my shoulders are forward, I've compressed my diaphragm. Now I'm breathing from my upper chest and I'm elevating that rib and I'm just pushing that rib up against in between the clavicle. I'm putting tension on, creating activity in the scalene muscles. I mean, I'm doing
yeah,
all this mechanical stuff that's causing compression. And if you got a sensitive nervous system, a nervous system that's sensitive enough, you know you're in trouble when breathing is making it worse.
yep.
Um,
That's thank you.
and it,
That's
it
that's a
does. It complete. I mean, just I mean, even just resting someone's arms. I mean, I'll tell, and people do this anyway. I'll say, put your arm on a pillow. Oh yeah, I do that a lot. That feels better. I'm going. You're unloading this. You're unloading the nervous system. That's
there
why
you
it's
go.
better. It's not a magic trick. It's a mechanical change.
I have personally had that myself and done that myself. I think I've shared this with a few people. Uh, Several years ago, I worked at a place that had old style radiology films, and it meant pounds and pounds and pounds of folders where you'd be digging in them, throwing up films onto a light box, shuffling like hundreds of pounds of films back and forth, and did this for 8 hours a day. And I started getting symptoms in my right arm, I believe. It's been a while. And I'm like, okay, I have to get an MRI. And they did an MRI of myself. And I didn't have a 20-year-old spine like I expected for some reason. But all my neural foraminal stenosis was on the left side. My symptoms were all on the right. And I'm like, this is TOS. It can't be anything else. It's doing exactly what I should be doing. And the
Right.
cause is exactly the cause of so many of our patients. And one of the things that helped me the most, Steve, was putting a pillow under my arm and elevating that shoulder and taking the loading off. I can totally assimilate with what you're saying.
Right. Um,
We have more questions from Jorge, and I want to keep him rolling. So he says, I can relate on regular PT exercises don't work. I understand the Invest program has deep neck flexor exercises. Can you please elaborate on how these are done?
well, the good thing is, although I've deep neck flexor exercises are not unique to TOS. Uh, so there are things online that do show some deep neck flexor strengthening. Now, I have to say I've looked at some of them, and I tend to gravitate towards the more gentle, conservative um, exercises. But I think if you want to go and we can talk about posture again because this is where I think it would go. So if you go back to that slouch position, and then if we're looking at a computer, our chin is up. Okay. So what the deep neck flexor does is it brings the chin down. Now we're not saying down, but just levels it. So by getting into this better position, we're aligning ourselves I mentioned before about, setting the shoulders was the second last thing I did. The last thing I do is just lightly activate the deep neck flexors.
Hmm.
By doing that, I'm aligning my spine, my head on my cervical spine. The scalenes don't have to work as hard. When you're in a forward position, your scalenes are working harder. If you're in this more aligned position and you're strengthening the deep neck flexors, again, the scalenes are more relaxed, but then everything else is open and you're breathing from the diaphragm. So you're taking all these pieces and not trying to take one piece, they all have to fit together. So it's never one thing. It's always several things because they all fit together. And when you're collapsed, everything falls apart and compresses. When you're straight, everything opens. I'm going to say this again, though, is that I can be this position. I don't necessarily feel better that second,
Hmm.
although objectively I might see improvement. So people don't always see the connection between doing the right thing over time and seeing improvement. But um,
Okay. Thank you.
but
So, just a quick thing, the Cabot test, does that measure something related to the deep cervical flexor, Steve?
oh, that's exactly what it is. Yeah. So the so Cabot was another doctor, a neurologist that Peter. Well, he was been around for years and years, like through Kaiser, um, and then he was looking at. Interestingly enough, he was looking at back pain that was caused from a cervical disc compression. So he was saying unresolved low back pain with traditional methods and saying, well, would activating the deep neck flexors or having a better alignment, an instability problem, would that relieve the back pain? He has a book on it. I have the book. And then he was going into looking at when Peter ran into him, he's looking at arm pain and deep neck flexor weakness and instability. And so Peter was picking up on this idea that, oh, I need to strengthen the deep neck flexors. He had a thing called the thinker pose, which is really a deep neck flexor strengthening exercise. And for some patients, that little addition of the neck being in a better position, strengthening the deep neck flexors would sort of reduce some of the compensation of the scalenes, um,
Uh,
and people would feel better. And the people that first developed these deep neck flexor strengthening exercises were looking at patients that had sort of cervical instability from like car accidents, whiplash. So um, there is a test that, and not to get into, there used to be a thumb test. So
yeah.
Dr. Cabot would resist the thumb adduction, and then he would see if it would break. He would do sort of a thinker pose, deep neck flexor stabilization exercise, and your thumb would get stronger immediately.
Yeah. Fascinating.
It's crazy. And so what we've done is we use a little squeeze bottle that's attached to a tube to a blood pressure cuff
So you
gauge,
can measure it.
and you can squeeze it and see the gauge move,
That's
and
cool.
then you compare right to left. One hand's weaker. You do the thinker pose, the needle goes up, sometimes dramatically. If that happens, we know we really have to focus on um, deep neck flexor strengthening, but we do anyway. But
Huh.
it makes it clear that breathing isn't going to be enough.
That's
Or
really cool, Steve.
posture, well, I mean, posture is deep neck flexors are in there, but we're trying to actively strengthen the deep neck flexors just rather than sitting better.
Whereas further questions, have you seen a shoulder? I don't know if you mean an orthotic, like a joint replacement or arthrodesis. I doubt you mean arthrodesis. So I'm going to guess, have you seen a shoulder replacement help patients Or orthosis, does he mean like maybe a
Yeah, maybe
sling?
like a sling or
Yeah.
some kind of um, I mean, if you're, I don't see people. I mean, shoulder replacements and TOS don't seem to. Those people don't cross paths. I'm not saying they don't have it, but and if you're talking about some kind of a sling or a posture vest or one of those figure eight measurements, I mean, I don't even know if you would even talk about Dr. Newkirk's vest as
Mhm.
being. I mean, again, not sure if you're asking that question. Um, um, the vest is custom made, so it fits like a glove. So it's also very expensive, but I've had patients that have had some benefit from it. It's a it still has to you still have to work with the system and work with getting spinning, calming things down. But if you're talking about just a strict like a figure eight, um, and I'm not sure if you're asking that figure eight sort of a attachment or some kind of a vest, most people don't find it super helpful. And sometimes the way the straps run or the position of the supporting things create more compression than they do help. So I'm not sure if that's answering the question.
Okay. Thanks, Jorge. Appreciate it. Superman. Is that like redundant man? I'm joking.
I don't
S-
know.
Stecco's, I assume Superman is already pretty super. All right. And I love your dog pick there. Very handsome dog. Stecco's fascial manipulation is a new emerging concept for treatment. And what are your thoughts on this, or I guess on fascial manipulation in general?
um,
Do you work with this much? I don't know if it's out of your.
I just was looking it up, and it looks like is this in Italy? I see the Fascial Manipulation Institute by Stecco, and it's out of Italy. Um, I don't know anything about it, and I'm always interested to hear what other people are doing. Um, but until I could have somebody who personally had an experience, it's always kind of hard for me to know what
Mm,
to recommend. Um, I do have a few patients that are seeing myofascial release therapists, and there are some really good ones, but I think you have to find the really good one.
mm,
They need to be, I think, not aggressive, and sort of peel the layers kind of an approach. Um, and for most of those people, it seems like, and they've told me the same, was that it was just an adjunct to what we were doing or an adjunct to something else. So it didn't seem like it was the only thing they would do. Um, but I'm not against it. But I do tell people to be careful about deep tissue massage types of things where people are kind of digging in and being,
mm,
kind of being aggressive. Just because, again, of what patients have told me, I'm not, I, m- everything I'm telling you right now is not a personal belief. I tell patients I'm relaying what other patients have told me.
right.
Um, and if they told me standing on their head would make them better, I tell you to stand on your head. But and I'm not trying to make light of this because I don't want to make light of this problem. It's not a good problem to have whatsoever. But um,
There's a surgeon we've worked with occasionally in the Midwest, and he talks about the corticoclavicular fascia. Something I've looked at on MRI. It's very hard to see because it's just very thin sheets of soft tissue. So I don't have a lot to add either. And like you, I give the warning that just stuff I've heard, which doesn't have research backing it up or my personal experience. Um,
and I've had a lot of the well, I should say a lot. There part of the exercises in the Edgelo in the Invest program are movements to sort of I say move the body, in which I got to assume that when you're moving the body, you're moving the fascia. Um,
mhm,
we're also doing stuff with, and again, it's not a lot of patients, but we do some cupping,
mhm.
which
Oh,
for some people have helped. but the person's really thinking they need myofascial work, then I try to direct them to an expert because I'm not an expert at that. And and I don't want to pretend like I know more about that than I do.
Okay, I'm going to, let's see, I have to skip a little bit because we have a hard stop at 6 p.m. our time.
Okay.
So I'm going to take a look. You'll all pardon me for looking down at my computer screen, which isn't my camera. And I'm going to grab, we have Jackie who has a question and Gabriel B. We could grab one or two of your questions depending on our time. And you know what? I thank everybody besides Steve for sharing, but I thank everybody who comes in here and contributes and participates so much. We have some really good questions. Number one, we hope we're helping people through our expert. And number two, I appreciate the effort that people make to have a really healthy dialogue. So forgive us if we can't get to everything. We will hopefully in the next talk. So, Herb, let's start off. Gabriel B. Hi, and thank you for this talk. Thank you for being here, as I've said. Have you seen people with Parsonage-Turner syndrome? That's an inflammatory process, often a post-viral syndrome of the brachial plexus. Have we seen those patients along with TOS, and any thoughts on the difference of treatment? I can tell you that it's kind of a different clinical presentation, the rapidity of onset, often the relationship to a previous virus when you have Parsonage Turner. On imaging, it looks different because the changes are centered around the brachial plexus, which is inflamed. So it's not secondary to compression or tension at one point, which we can usually see differently. If the brachial plexus looks abnormal in TOS patients, it's often in one area where you get multiple parts of the brachial plexus, but still in one small space. Whereas Parsonage Turner will tend to look like diffuse involvement and inflammation of the brachial plexus. So both clinically and imaging wise, they tend to be different. And no, I haven't seen a patient who has both of them yet. Steve, anything to contribute to that question?
Yeah, and you already described more than I know. Although I tend not to see I tend to see the TOS patients. Now, I do think there are cases of patients, especially I know it's not quite the same thing, but you get people that get a trauma, a whiplash, fall, where I think you could argue they had a normal space and they just got a tractioning injury of the brachial
Hmm.
plexus.
Hmm.
So part of my treatment there is to still look at postural problems that could compress the irritated brachial plexus. Um, Looking at breathing not only from a just a relaxing the scalenes, but just kind of the sort of just tap down the nervous system and use the same principles of like trying to calm things down. But I got a feeling more that it's less about space compression and more about brachial plexus trauma injury.
Hmm.
Um, and so, but as far as the as far as the inflammatory brachial plexus injury, condition, I don't see that, and I don't know if those patients just get better with time and medication, or I don't
Yeah,
know.
I kind of headed it off the question because no one's going to send a patient with that disease to a physical therapist primarily. So
Yeah,
I would be surprised if anyone came to you with that diagnosis. Thank you for the question. I appreciate that. Uh, Angaku, is there a connection with TOS and cervical instability? This is a big can of worms here. If so, how does one address cervical instability along with TOS?
I
Um,
don't.
Boy, a lot
Yeah,
of people are looking at cervical instability now, right?
right. Um, I don't think is. I think they can exist together. I don't think that they're one necessary. I mean, I know TOS wouldn't lead to cervical instability. I'm thinking of it from a structural disc instability, ligamentous problem. So that mean the thinker pose was for cervical instability,
Hmm.
and I think those symptoms were caused from the cervical instability, not the TOS. I just think that they exist together, and I think because they're so closely linked as far as posture to open these spaces and then also to activate the deep neck flexors,
Mm,
I think it makes sense to bring them all together. Um, but I have people that come in with cervical instability, and if it's bad enough, they're talking about fusions and
mm.
disc replacements, and it's a different thing. Um, but I think they both cause like tremendous problems, and one kind of feeds in on the other. I almost feel it's I don't want to say it's I think we know more about treating cervical instability than we do about TOS. I'm not
I will
saying
say
me,
that
I'm just saying
there's a
as a
ton of attention on social media. A couple people who seem to know everything, which I don't think is the case because the literature doesn't know everything, but they're talking really craniocervical junction, laxity of the ligaments that hold the atlas and axis, some secondary involvement of the jugular veins by compression if you have an abnormal enlargement, a part of the atlas, and then a bunch of docs in different countries and in this country who have different methods for addressing this. So I've seen it really blossom on social media. It's constantly coming through, and I don't know enough about it to comment intelligently or to help anybody. But there's a huge amount of traffic on it, and so I'm going to
huh,
at this point say, boy, that's a topic that I'm going to mark down actually on Gaku for something. Maybe we could get an expert or two on here to discuss it in the near future. But I'm not going to venture more than that. Um,
right. And when we're talking about the thinker pose and that kind of cervical instability, the um, the goal is to make the through posture and strengthening to sort of address it. If it's truly unstable, um, that's a different problem.
Thanks, and thanks for the question. D cells. All right. Can you speak to Gilat Sumner in NTOS? I've not been diagnosed, but I do have many inline symptoms. I think Gilat Sumner is TOS where you also have involvement with atrophy of the intrinsic muscles of the hand. It's one of those eponyms that I think Gilat was at LSU in the 70s, if I recall correctly, and published some papers that are interesting. But um, if I'm remembering it correctly, my concern with Gilat's on her hand is that once you get atrophy of the muscles of the hand, it means you've had enough motor nerve fiber involvement that you've got the atrophy as a result of that, and it's much harder to get that back. It's kind of late stage neurogenic TOS. Patients start out with symptoms, but no signs. Like you can't really find physical weakness. Maybe you find a little bit of anesthesia on test, but patients first start out with symptoms and they tend to be intermittent based on how much they work that day or their arm position. Then it tends to last longer overnight. Then it tends to last over the weekend. Then they get worse symptoms that are now measurable with some clinical tests. And then later in the process, they get this muscle wasting. So we always want to get there early because once you get motor fiber involvement, it's much harder to recover. Steve, you want to contribute to that at all? I don't know if you've heard that term.
No, I haven't. I don't see many people that have gone that far,
Good.
um, progressed that far. So I probably go back to what you said about just you know the whole issue with treatment for TOS is like finding the proper treatment early enough to be effective, and the longer people have to wait, and it's not through any fault of their own, but through sort of the missteps of their providers and
Yeah. Having a
all this
doctor who
stuff.
helps you find it.
It
Yep.
just these changes become more and more sort of set. Although I've had patients that have had it for a number of years, um, again, but they don't have the atrophy of the hand muscles, but who have gotten better. So I don't always know if the length of time is going to naturally lead to that, or it's just a worse version of what's already a horrible thing.
Now, I'm going to jump in here because we've got about 3 minutes left. I want to make a couple of quick announcements. First of all, we at Vanguard Specialty Imaging are happy to announce that we have a new imaging partner in Atlanta, Georgia, Amera Imaging, and they're a great organization with multiple imaging centers, and we are now working with them doing our Nia Vista MRI in the Atlanta area. And interestingly and coincidentally, in 2 weeks, we have a live stream coming up with two very experienced docs, young and progressive and smart, who work at Emory University that just happens to be in Atlanta, Georgia. And that's Dr. Eric Wagner and Dr. Robbie Bowers. And that's going to be a very, very informative talk. They may not have as much experience as Steve, because few people do, but they have some really great progressive ideas. One is a surgeon, that's Dr. Wagner, and the other one is a sports medicine doc, a team physician actually for several teams there. So they have a fund of knowledge, and it's going to be really enjoyable talk. And now I think we can answer. I don't know if we have enough time to answer one more question. I really apologize to the people who hung out here with their questions. Please come to see us next time in 2 weeks, and we'll answer as many questions as we can. Steve, as always, just I feel more enlightened. I hope our viewers feel enlightened, and thank you for your time and for sharing.
Oh, again, I'm thankful to be here, and I'm just here to help. I mean, Peter was always there, and I just try to follow in his footsteps. And I'm not Peter, but I'll do the best I can.
And people out there, reach out to us at tosmri.com. That's tosmri.com. Go to the big button that says contact us, and we can put you through. We can connect you to Steve for any questions you have. We don't have any relationship except a professional relationship, and trying to both sides here. We're trying to help patients get better. I'm Dr. Scott Worden, the TOS guy. Thank you for showing up and viewing and asking wonderful questions and participating, and we will see you next time.
Thank you. Bye.